All right, continuing on in our special challenges in obtaining a patient history. Intoxication. When somebody is intoxicated, they have a hard time being rational. The alcohol kind of dulls their senses, and there's a very high potential for violence and physical confrontation. Don't put a patient that's intoxicated in a position where they feel overwhelmed or threatened, because that increases the chance that they're going to um, become violent towards you. If they feel backed into a corner, the only option is to come directly at you. So definitely give them a way to get out of where they're at. Definitely give them some room to breathe, and don't just tell them that they have to. They still have some decision over themselves. If they're not ANO times 4 because of the alcohol, you do have a little bit more leeway, but don't tell them you have to do this because I say so. It's not going to go over well. Crying, I think this is the thing that I have the most trouble dealing with, is somebody that is just hysterical and crying. It may be that they're actually in pain. It may be that they're sad about the situation, or they could just feel overwhelmed. Sometimes when people get super frustrated, they just cry because they don't have another way of dealing with the situation. Try and be calm and patient, reassuring. Talk to them in that nice, soft voice. Don't yell. Don't say, stop crying. Say, okay, I need you to take some deep breaths for me. And you can breathe with them, to kind of help them get themselves under control. Depression. Depression can be extremely severe. It's among the leading causes of disability worldwide, and that's legit. Some people go one way where they just are sad, they're hopeless, they can't do anything, they don't want to get out of bed, they don't eat, or they go the other way where they're eating all the time, and it's hard. It really is. A lot of times when somebody is severely depressed, they don't want you to necessarily fix their problem. They just want you to listen. That's the biggest thing, is that just listening to them can often be the biggest help. Most of the time, somebody with severe depression feels like they're alone, like nobody cares, nobody understands, because everybody's telling them what they have to do rather than just letting them get their frustration and the problems that are causing them to feel that way out into the open. Confusing behavior or history. Sometimes our patients have medical conditions that make it really hard for them to put the puzzle pieces together, and they really can't tell you what's going on. And it gets rough. It's hard. Some patients have dementia, delirium, Alzheimer's disease, where they don't know their own name, let alone what's going on with them. You can tell they have a problem, but you're not able to pick the pieces together. Hypoxia, however, is the most common cause of confusion. So you get some oxygen on them, get their SATs up, and then things might start clicking a little bit better in their head. They have limited cognitive abilities, make sure that you keep your questions simple. You can still ask open-ended questions, but maybe more pointed questions so that it's easy for them to understand. Try and keep medical terms out. Oftentimes when we talk to our patients, we'll throw out a medical term and then explain it. With somebody that has limited cognitive abilities, don't do that. Make sure that you ask your questions until you get the full answer. Sometimes you have to ask the same question a couple of different ways. Rely on the presence of family and caregivers to supply your answers, but don't forget to talk to the patient. Don't just talk to the family, talk to the patient themselves. With cultural challenges, they already have a hard enough time understanding our language. So don't throw in medical language at all. They may end up wanting to have somebody the same gender as them. Try and get assistance from friends, family members. If you have somebody that can speak their language, obviously that's a no-brainer. Have them take care of that patient. If there's a language barrier on top of cultural barrier, try and find an interpreter if possible. Remember that you can use family and friends, but they may be editing what the patient is actually saying because they're going to input their own bias and their own understanding. If you can't, make sure that find an interpreter. Make sure the patient understands who you are. Keep talking to them. Make sure that you kind of show them the equipment that you're going to be using. Lots of hand gestures. Don't yell at them. They're not deaf. They just don't know your language. People with hearing problems, ask your questions slowly and clearly. If you need to, a trick that we all can use but sometimes forget about, use a stethoscope as a hearing aid because it will amplify the sound. You can learn simple sign language to help with communication. Paper and pencil, we all carry that around with us, or we should, not a pencil in particular, but a pen, so that they can write down what's going on. Visual impairments, identify yourself verbally when you enter the scene. If you've got something that you move to be able to get to the patient better, you've got to put it back because a lot of times they have the outline of their house memorized so that they don't bump into things. If you move it, they're going to have a hard time with that. Explain to the patient what you're doing, what sounds are around them. We already did talk about that a little bit, but I mean, just to revisit it. Your secondary assessment. After you finish your primary, you're going to decide are we going to stay and play or are we going to load and go? A lot of times you can go ahead and initiate transport and then complete your secondary assessment. That's not a problem. Even on a non-critical patient, you can still do that depending on what your transport time is to the hospital. The purpose of this is to actually go system by system to examine the patient. A lot of times we're going to do a brief head to toe and then focus on these body systems that are involved in the complaint. So there's 3 different parts of this. There's inspection to actually look for abnormalities. There's palpation, which means to touch or feel for abnormalities. And then auscultation, you're actually going to listen with a stethoscope. And typically you're going to do it in that order. Look at it first, touch it next, listen to it third. For your secondary assessment, you're going to use the mnemonic DCAP BTLS. So this kind of tells you overall what you're looking for on the patient. So deformities, contusions, abrasions, punctures, burns, lacerations, swelling, tenderness, and I know I got those out of order because I couldn't remember what the T was for a second. But that's kind of overall what you're looking for. Do I necessarily say DCAP BTLS every time I'm looking at a patient? No, I haven't really used that mnemonic in a very long time because normally I just say what I'm looking for. When you're looking at something like that, you want to compare one side of the body to the other. So see if they have symmetrical changes. If they have a lot of swelling in their right wrist, if you hold it up to the left wrist, you should be able to noticeably see a difference. You want to systematically assess the patient. So if you are all over the place, you're jumping around, you're probably going to miss something. You want to go start at the head and move yourself to the toe if you need to do a systemic. If what's going on with them is relatively isolated, you may not have to do a head to toe. You may go more into a focused assessment. So this is typically for a patient that doesn't have a significant MOI. They're responsive and they can tell you what's going on with them. So you'll focus in on that body system or the couple of body systems that could be involved. For the respiratory system, you want to expose the chest, look for signs of airway obstruction as well as trauma to the neck or chest. Even though we've already done this, double check it. Make sure you didn't miss something. Inspect the chest for overall symmetry. Make sure that the rise and fall is equal and that they aren't using muscles on one side and not on the other side. You want to then make sure that you're kind of feeling as well, so your palpation portion, to make sure that everything feels stable. You're then going to listen to breath sounds. There's several different spots that you're going to listen to breath sounds. There's 4 at least on the front, and there's 6 on the back, and I will show you those during lab day. You want to measure the respiratory rate, the chest rise and fall for tidal volume to make sure that it's adequate, that they're not breathing too shallow or too deep, and then effort. Does it actually look like they're struggling? You want to look for retractions, increased work of breathing. If the patient's unconscious, you can actually feel through the mouth or nose during exhalation to see if they're breathing adequately. Other things, respiratory rate, normal for adults is 12 to 20. Remember that if they're above 28 or if they're under 8, we should be bag valve masking them. Children breathe crazy fast sometimes, so they're going to be above that 20. You want to count the number of breaths in a 30-second period and multiply by 2, except if the patient doesn't have a regular rhythm. Then you definitely want to count for the entire minute. If the patient has a very regular rhythm or relatively regular rhythm, you can go ahead and do the 30-second method. However, don't tell your patient you're going to check the respiratory rate, because when I know somebody's counting my breaths, I'm going to breathe all over the place. I'm very, very conscientious, and I'm not giving them a good look at what's going on. Quality of breathing, normal breathing is silent. There's nothing going on with normal breathing. If you have sounds that are going with breathing, something's not right. Depth of breathing, are they taking in enough air to actually sustain the oxygen demands on their body? And then breath sounds. You can almost always hear breath sounds better from a patient's back because they don't have as much tissue in the way that's going to obscure that sound. So you're not just going to listen once on either side on the chest and then once on the back. You want to listen to all the lobes. Remember, there are several. So you want to make sure that you cover all of that. Any sort of sound other than just normal breathing, then you kind of want to do a little more investigation. And each sound kind of has a specific underlying cause that tends to be normal. So here's one spot on the chest on the front and one spot on the back. We'll show you these during lab day as well. Different sounds that you're listening for. Normal breath sounds, when you get an opportunity to listen to breath sounds, do it. Even if the patient is not in distress, because in order to realize what abnormal is, you need to realize what normal is. Snoring breath sounds, typically the tongue is back. Wheezing breath sounds are constriction within the airways. Crackles, that tends to be fluid in the lungs. Rhonchi is mucus. And then stridor is upper airway obstruction. It's typically either something's blocking the upper airway or the larynx itself is inflamed. We'll continue on in the next one.